that in mind, remembering that there are real people who are involved in this, there are real people who are affected. There is a mother in here today, mother out there today, whose child has been diagnosed with cancer, whose child could survive, right? But it is a function of where that child has been born. It is a function of where the mother lives. It is a function of the economic capacity of the mother and the father, and that's not fair. It's unjust and it shouldn't remain. And so that is what I want us to keep in mind as we go into it. Having said that, I don't want to make everybody depressed and sad. So thank you. Welcome to the program. We appreciate your being here and we look forward to an impactful program. Thank you so much.
Thank you so much, Dr. Joseph, for that wonderful remarks. Now we would be going into the event properly. And to take us further, we're going to the keynote speech now. As we welcome Our Excellency, Dr. Zainab Bagudu. Dr. Zainab Bagudu, Dr. Zainab Shinkafi Bagudu. She is the founder of Medicaid Foundation. She is the chair lady, first lady against cancer, board member, Union for International Cancer Control, and she is the first lady of Kebbi State. Ladies and gentlemen, please join me as we welcome Our Excellency, Dr. Zainab Shinkafi Bagudu, as she takes us on the keynote speaker. Welcome, ma'am.
Good afternoon, Korede. Good afternoon, everyone. It's a pleasure to be here today on this webinar organized by Dorcas Cancer Foundation in partnership with Clinton Health Initiative and the Ministry of Health. I'd like to, first of all, congratulate us all for coming together to mark the International Childhood Cancer Day. It's one of the cancers that is very dear or very important to us activists and advocates in the cancer space, because it is one of the cancers in low resource settings, low middle income countries, whatever you wish to call us, such as Nigeria, that, as Dr. Joseph has enumerated, creates a source of concern because of the wide gap in disparity that exists between us and them, if we put it that way. Worldwide, over 400,000 children are diagnosed annually with childhood cancers. However, the survival rates in high-income countries is in the region of 80% because of various reasons. The tools exist to treat it, there's easy access to the drugs, but most importantly, it is diagnosed properly. For us in our parts of the world, diagnosis usually comes late and the health system is quite weak, and so the referral process is slow. Human capacity or human capital that is required to make the earlier diagnosis is delayed. While preparing for this talk, I was looking at some literature and I found that there was a 15-week time lag in Enugu, which is comparable to what was found in Ibadan. That is the time that is required to make a diagnosis from the onset of symptoms that are attributable to the malignancy. So this is compared to about 5 weeks in other high resource settings. There and there, we can see that there is a problem in making the diagnosis. And so we have to focus a lot more on how we can work together to increase the capital or the resources that is available to our healthcare workers. By this, I mean the skills that are necessary, the infrastructure that is required, all the supportive diagnostic material that is required to support that, making that right diagnosis. Because obviously the healthcare workers can have the skills, but if they do not have the infrastructure, the right laboratories, the right reagents to be able to look at the slides and so on and so forth, it would be very difficult. So it's a whole, a big problem that we can address if we focus on properly. I'm glad to say that realizing this fact, one of the goals of the global initiative that was launched by the WHO is to focus on how to close this gap that exists between the various countries of the world, because it can be done. And so the about the launch of an access that will enable low middle income countries access diagnostic treatment for childhood cancers at a lower rate, and so will improve the outcomes of childhood cancers. I know that we have a lot of issues in our country, and if we come back to focus on it now, but there have been some good initiatives, such as the chemotherapy access program that's from the Federal Ministry of Health that I believe is led by Chai, and they help us to be able to access the pediatric childhood drugs. The WHO program that is being launched today is a similar program, but this will be more global, and hopefully Nigeria will be able to participate in that. So I think that my point today is to just focus on the fact that childhood cancer is a problem, albeit is less so a problem than infectious diseases and other childhood problems like malnutrition. But it is a problem, and we know that our statistics is also weak. We can have better statistics. And if we focus on helping or on improving the situation around it, the issues come from three parts: the parents and caregiver, the disease itself, and the healthcare structure or the health system. So I am talking about the health system. If we focus on all these three parts, increasing awareness for the parents to go to the hospital at the right time, to be able to notice that this is not usual, just any other normal illness. And then of course on the health system, working with the healthcare workers, trying to improve their skills, trying to improve our hospitals. And that is where I must commend organizations like the Dorcas Foundation that has worked or has been working tirelessly to help to increase these skills amongst our workers. And also with the disease itself, that there we have to be able to appreciate the fact that there's some things that are beyond our control. Some of them are easier and can be diagnosed quicker than others. But for the majority, the chemotherapy agents that can treat these cancers do exist and can be accessed. So I again congratulate Dorcas Foundation and indeed all other advocates that have come together to work on this issue in Nigeria. We need a huge amount of awareness. We need to educate ourselves more. A lot of people don't even believe that cancer exists in young people. So starting from there, we have to work hard to let our people know that these things do exist and we can do a lot more to improve the outcomes that we're currently seeing. I also must commend the world bodies like the UICC that I belong to and the International Society for Pediatric Oncology that are really increasing the conversation and placing this problem on the world agenda, on the world global agenda, so that we can have improved aids that will help us, particularly in our low resource settings. So I hope that we will learn a lot today from this webinar. I will be happy to take any other comments and questions at the end of it at the right time. And I wish us all a very fruitful afternoon and enjoy your International Childhood Cancer Day. Dr. Joseph is not wearing gold, neither is Korede, so we should find them and help use the dues that we raise from that to help a child with cancer. Why are you not wearing yellow, Korede and gang?
I have a good ribbon.
It's not good enough. You have to be. Look at me. I made an effort. Dr. Joseph is in black.
Oh, a good ribbon. Let me just show my ribbon.
That's good. Yes, well done. Well done. Thank you very much for listening and have a pleasant day.
All right. Thank you so much. Thank you very much, Ma. Please, I would like us to make these very interactive. Please, let's use the reaction button to celebrate our speakers each time, and then we can also use the chat sessions to also drop comments. And please, let's note that the Q&A platform is for questions. Please, let's endeavor to please drop our questions on the Q&A platform so that we can easily pick it and then we can get answers to the question. Thank you so much once again, Our Excellency, Dr. Zainab Shikafi Bagudu. we would move on to the next speaker now. Our next speaker who should come up now would be coming by force. So we will be moving to the next speaker now. The next speaker now is Professor Dr. Alan Davidson. He is the advocacy chair at the International Society of Pediatric Oncology, SIOP. He will be speaking on the advocacy for childhood cancer in sub-Saharan Africa. Please let's receive Dr. Alan Davidson. Can you hear us there? Can we hear me?
Also, the relatively low cost of Davidson, and I am the advocacy chair of the International Pediatric Oncology Society. I have the pleasure of being here with you guys today on International Childhood Cancer Day, and I'd like to thank Corrado Akindele for the invitation to speak in your wonderful Dorcas Cancer Foundation event. See, I'm sharing my slides now, which is titled, of course, Through Your Hands, the Role of Healthcare Professionals in Improving Pediatric Care, Pediatric Cancer Outcomes in Africa. My talk is entitled Advocacy for Childhood Cancer in Sub-Saharan Africa. First of all, let me make an investment case. What we do is value for money. High-income countries have shown that there's an overall survival of more than 80% is possible in childhood cancer, and the length and quality of that survival adds value. Also, the relatively low cost of treatment is proven. There's some very good data from Ghana that illustrates this point. And we can add value in other ways by supporting, as we did in late 2021, universal health coverage, by raising the quality of subspecialist services in general, and by collaborating on drug access. So what's the size of the problem? Well, we have to be honest here. Childhood cancer is relatively rare compared to adult cancer, but the global burden is very significant. Looking at data from the major centers in South Africa, you'll see that we are reporting about 90 new cases per million children under 15 years each year. That ASR, that is an age standardized rate. So that refers to the age band. And you can see that our 90 odd cases is somewhat lower than the 130 to 150 cases per million children reported in high-income countries like Ireland and the United States. It is significantly lower than the 840 new breast cancer cases each year per million women in South Africa, keeping in mind those are of all ages, and an even higher burden of breast cancer in the US. But even assuming this age standardized rate of 100, the lower rate, with a total population of nearly 1.15 billion Africans in sub-Saharan Africa, and assuming, which is reasonable, that about 40% are under the age of 15 years, that would imply or give us a number of about 45,600 new cases per year among children in our region. Of course, that's not what we're seeing. We know that we are struggling to find all of these cases. So our relatively low age standardized rates, that we refer to this as under ascertainment, so a low total number, and this is due to underdiagnosis, and also under-reporting. So some children are diagnosed and not reported to registries. So what can we do? We can build and maintain registries, we can build networks, and we can also educate students, nurses, and doctors. And I make that point because parents take their children to the clinic or the local doctor or the hospital. It's often in the health system that the holdups occur, not because parents don't recognize that their kids are sick. And so a big focus of our early diagnosis campaign needs to be focused on the healthcare sector. But let me move on. So what's the context of cancer in the low and middle income country setting? So before the year 2000, about 10 million children died before their 5th birthday every year. 90% of them in 42 countries in sub-Saharan Africa and Southeast Asia. And of course, all the usual suspects: prematurity, intrapartum death, pneumonia, diarrhea, malaria. And health priorities, of course, focused and will continue to be focused on these conditions. What's exciting and important is that major initiatives, so USAID, Gates, and all, in association, of course, the World Health Organization, have made a massive difference to the global under 5 mortality, which fell from around 10 million at the turn of the millennium. Within 10 years to 7.6 million. By 2013, it was down to 6 million. So that's very encouraging. Encouraging in the sense that it means that other non-communicable diseases become the focus now of our efforts. And also that more children are surviving, which is very important. So we know that from the 60s on, from the advent of multi-agent chemotherapy and multidisciplinary care, we saw in high-income countries a massive improvement in survival rates for many, perhaps you could say most, childhood cancers, with some notable exceptions like myeloleukemia and neuroblastoma. And the question is, how come there's such a big disparity between high-income countries and low-income countries in terms of survival rates? I think I credit Scott Howard, past General Secretary of SARC, with this particular slide. I thank him for it. He makes the point that, remember, the survival rate of children treated in a center of excellence in the capital city of a country is not the same as the number of children who survive in that condition in that country, because it's all about access. We've got to consider, if you go from the left here, how many people have access, how many get to be treated in a pediatric oncology unit, how many stay in treatment until the treatment is completed, and how many children stay in follow-up until the follow-up is completed. And so you can see that when these metrics don't work, you can get a very poor survival rate. And even when your survival rate in your pediatric oncology center of excellence is 50%, if your access to care is low, then you can see that your real survival rate is much lower. So the gap is a complicated and nuanced one. But the consequence is clear. The consequence is that we operate in a very uneven world from red to blue, where survival rates are lower than 25% in the dark red countries indicated, and then over 75% in dark blue. And so this is the focus of our advocacy initiatives, and of course of the Global Initiative for Childhood Cancer, which I referred to just now. So how is SARC tackling the problem? Well, really, perhaps you could say that the distinction is fairly arbitrary, but let me use these broad headings: collaborations with Childhood Cancer International, with a variety of research organizations, and with other actors who sponsor treatment protocols, and then engagements with the World Health Organization, governments, and then with international agencies such as St. Jude Global. So let's look at some of these. And this is not in particular order, it's just a helpful way to look at this whole paradigm. So the first thing is harmonization. Now, operating in Africa, we have the French African Pediatric Oncology Group, highly successful in West Africa, Francophone West Africa, and in the Maghreb. And they've collaborated wonderfully with help from France, of course, and they have done a lot of impressive research and improved survival rates across the region. So they have protocols. SIOP has sponsored a variety of adapted treatment regimens. I put one example here in this slide. INCTR have got treatment protocols at centers that they have sponsored. St. Jude have been assisting some of the centers where they work, and they're of course working on a big project for adaptive management. Global Hope, which is the program out of Baylor in Texas, have also working in a number of centers across Africa. And then even the NCCN, which is largely adult-focused organization, have started to consider doing pediatric protocols. And of course, the bottom line is we want everyone to be ideally talking the same language, sponsoring or supporting roughly similar guidelines so that we can learn rapidly and collectively. What about research? Now, I reference here an old friend of ours in the Society for Neuro-Oncology's Sub-Saharan Africa branch. Rakesh Jalali out of India has done some amazing things, and he's been a speaker at a number of our meetings, and I stole this slide from him with permission. And one of the points that he makes is that we suffer so much in lower income country settings from a lack of time to prosecute important research. So often it's just about getting the resources and treating the children, and that does hamper our efforts to do appropriate and relevant research to improve both our care and our outcomes. And so his bottom line in red in this lovely slide is start with a registry, ask a small question for each disease, and collaborate to build momentum. And really his point is it can be done and it should be done. And I will say that the society is sponsoring a new project, PARK, which will be specifically looking at trying to improve and increase the amount and quality of research in low and middle income countries. So we have an advocacy committee, which you can see has diversity across continents, across disciplines, and these are the people who are prosecuting the agenda on all our behalves. And you can see, of course, your colleague Corrado is one of our members. So what about the Childhood Cancer International? This is the major group for parents, survivors, and children suffering with cancer. And we have a very close, in fact, a growing close relationship that's growing as we speak, as we work our way through the annual program, which I'll chat to you about in a little while. Now you can see here across 14 countries in Africa, there are CCI affiliates. We want to fill that map up completely with yellow, but it's exciting to see these amazing organizations, including, of course, your own Dorcas, across the continent. And that local synergy between the local treaters, local governments and departments of health, and the local Childhood Cancer International affiliate is critical in our operations, because so much of the excellent work in advocacy is done at the local and country level, as well as regionally. So the year sees three major activities. We have International Childhood Cancer Day on February the 15th. We have a focus on survivors in mid-year in June, where we started our first webinar was last year, and this is a growing campaign. And then we have Gold September, where through the month of September, the color that's associated in international oncology with children, which is gold, is in focus. And we had a very successful Gold September last year, and of course, you guys right here and now are part of this year's ICCD celebration. So currently, there's a 3-year campaign it focused in 2021 on children, and that handle or hashtag was through our hands. This year, it's on the healthcare team, and I emphasize all the members of the healthcare team, right down to janitorial staff, anybody who's involved in the care of children with cancer in those pediatric oncology units, because they are your team. And so our hashtag is through your hands this year, and next year the focus is on families, care providers, and the hashtag will be through their hands. And so we're asking people through these days and weeks now to paint a hand, to color it in. You can do it digitally, and then to post a message of hope, a message of we're also asking healthcare providers to do that, to post a message of support, on the tree of life. Now, we want also to keep on with a central message, which SIOP sponsored as part of our advocacy push, which is that children should have the right treatment at the right time with the right support by the right team. And we want to be part of the movement in pediatrics for childhood or child health in general. So child health for all, and we want to emphasize the importance of universal health coverage, because it benefits children with cancer, but it benefits also all children. We want to remind people that treating children is good value for money, with fabulous long-term results in terms of both outcomes and the contribution that those young people will eventually make in society. And lastly, that all oncology depends on access to essential medicines, and we're part of that on behalf of, or with the whole, not on behalf, but with the whole adult community. So this brings me now to our role in WHO's Global Initiative for Childhood Cancer. We, through incredibly hard work by my predecessors in the advocacy committee at SAM, became a non-state actor at the World Health Organization, and so we have privileges to try and foster the cause of pediatric cancer. And one of the products of this engagement over time was the WHO that bought, in essence, the investment case, and they have put their money where their mouths are, as it were, and the WHO has now sponsored this global initiative on childhood cancer. I hope many of you have already heard of it, but just to talk about it, the bottom line is it focuses on the disparity we spoke about earlier, the fact that there are these low survival rates. Here you see again in some of the branding from GICC of 30% in low and some middle income countries. And the goal is to enroll governments with a package of goods, a program, a roadmap that shows them how to cater for childhood cancer in terms of service planning, how to make sure that the treatments that are given to children are appropriate and correct, and then finally how to, through this, to achieve 60% survival for childhood cancer by 2030. That's essentially the goal. And part of that is to deal with some of the myths, such as children do not develop cancer, such as that most children with cancer die of their disease, which of course, as you said earlier, is not necessarily untrue in low-income country settings, but it's not inevitable. It's something we really can change. That childhood cancer chemotherapy is expensive? No, we've shown it's not. That children, after being treated for cancer, are left with severe disabilities? In most cases, not. And so on. So these are important, and this is the sort of thing that Dorcas can help us with, to dispel these kind of myths in both amongst parents of childhood cancer sufferers and, of course, the communities in which they live. So the focus in terms of getting good early results is to focus on the 6 cancers that are most amenable to an improvement in survival: acute lymphoblastic leukemia, Burkitt lymphoma, Hodgkin lymphoma, retinoblastoma, Wilms tumor, and low-grade glioma. And the WHO is developing, or is busy developing strategies and packages of goods with the help of the community, including SARP. And also SARP is engaged along with other treating organizations such as the Pediatric Radiation Oncology Society, the International Pediatric Surgical Oncology Society, to develop specific treatment guidelines. These are called adapted management guidelines, and they fall under the ARIA bouquet. So these are being developed. So that really does, it's a great potential for harmonization, not just in the sub-Saharan African region, but also across the globe. And there are different levels of engagement. So you can see that there are countries, for example, well, specifically Ghana, Senegal, and Zambia, who are now focus countries for the GICC with formal Ministry of Health engagement. But there are also countries participating in GICC activities. You can see again Cameroon, Mali, South Africa, Uganda, and Zimbabwe. And then countries where there's dialogue: Ethiopia, Kenya, Mozambique, Tanzania. You can see also in the Euro region, some of the countries in Eastern Europe are coming on stream, and Morocco is also part of the GICC because, of course, they form part of WHO's Eastern Mediterranean region. So very exciting developments, and something that we want to keep on talking about and sponsoring. Then SARP is also, and this is a SARP project, but it's important that advocacy that our group keeps talking about it, is the SARP Global Mapping Program. So the idea here is to map services so that a parent in a particular country can have an idea of what's available, what's not available, so that also the organization, through its advocacy structures, is able to engage with local stakeholders such as ministries of health and government to try and improve cancer services. And so we've started in Africa, and you can see here, in fact, this is now a series of published papers that are coming out, looking at the African continent, and the broad results were a little bit sobering. So you can see that in terms of pediatric oncology medical services, most countries have full-time pediatric oncology doctors, but there are a few where there are not full-time pediatric oncology doctors. And there are also a few of the smaller territories where we weren't able to get information. Again, you can see differing levels of availability of chemotherapy, of radiotherapy, of specialized pediatric service, surgery services, I beg your pardon, and also trained pediatric oncologists. So it's an uneven landscape, and obviously something that we're hoping to improve over time with engagement with various countries. Importantly, there are a number of countries where there are no services currently. So up to 33 million African children don't have access, as things stand, to formal pediatric oncology services. I'm sure that doctors locally make a plan. I'm sure that they try their best and do whatever they can. I'm sure there are kids that are able to go across borders and try and access services, but it's a very tough situation for kids in these countries and for their families, of course. That all being said, the reason we're here today is not to wring our hands and talk about what we don't have. It's to join hands, smile at each other, and to say, little by little, we will get there. Malawians have a saying, pangono pango, and that's my message today, to say to you guys, we're all getting there. Keep the faith, stay strong, and please help us on our journey. Lastly, I'd just like to announce the 14th Congress of South Africa is happening this March in Kampala, Uganda, and there's a varied program for a variety of providers, both pediatric oncology, doctors and nurses, radiation oncologists, surgeons, and the like, and also a very vibrant parent program. So please do consider attending if you possibly can, notwithstanding the difficulties of COVID. And with an irritating dog in the background, my deepest apologies, and I'm sorry I can't be part of the Q&A, but I'm very happy, Corrada, to take any questions by email subsequent to the meeting. But unfortunately, I have another engagement during this symposium on Tuesday. With that, my friends, I thank you so much, and I wish you a happy and uplifting International Childhood Cancer Day. Thank you.
Okay, thank you so much, Alan. Please let's use the reaction voting if we get something. I'm sure he has communicated. And so we will be going to the next speaker now. But before we go to the next speaker, please, I would like us to just fix our eyes on the screen as we just quickly watch this video. Thank you.
I believe children have a unique situation because, unlike adults, they haven't had the time to build a network. They haven't had the time to build up property or own anything. When an adult is sick, they have people they can reach out to. They have friends they can call, family members they can call to say, I'm ill, I need your help. Children don't have that. Children haven't acquired any property over the years. They don't have a television to sell. They don't have a car that they can sell. They're 100% dependent on the financing of whatever family they find themselves in. A child that is ill wants to get better, but that child is dependent on the decisions that are made by his or her parents. If the parents decide that they don't want to seek medical care and they rather spend their time at a traditional healer or something, there's nothing the child can do about it. They have no power over their situation. Any property over the years. They don't have a television to sell. They don't have a car that they can sell. They're 100% dependent on the financing of whatever family they find themselves in. A child that is ill wants to get better, but that child is dependent on the decisions that are made by his or her parents. If the parents decide that they don't want to seek medical care and they rather spend their time at a traditional healer or something, there's nothing the child can do about it. They have no power over their situation.
Okay. Thank you so much. That's just a brief of the Dorcas Cancer Foundation. Let me just quickly just take us through. Okay, before I bring in our next speaker, the Dorcas Cancer Foundation is found after a child. Her name is Dorcas Adekpiton. She was diagnosed with osteosarcoma and she passed. Then Dorcas Cancer Foundation was found after Dorcas. Now, the Dorcas Cancer Foundation work on 4 tenets, which is we call the WIPGO, which is research, early detection, accurate diagnosis, proper and prompt treatment. And then so far, we've been able to train, in our early detection programs, we've been able to train community healthcare workers, which is over 1,000 plus of them in Lagos, Ogun, and Oyo State. And then we also have research program that we launched in 2018, which 3 research granting was given in research. So, and we have the 2021, 2022 ongoing right now. Also, we have our signature program, which we call the Pediatric Cancer Access Program. It's also a platform where we support the kids through direct treatment. Also, we've been able to train over 250 healthcare professionals on radiation oncology. So we had it sometimes last year there where we take them through radiation oncology, which was hosted by us, and then we have facilitators across both in Nigeria and outside Nigeria to take this. Also, our media range is over 2 million people we've reached with information about the early detection of childhood cancer. We launched the first childhood cancer handbook, which over 1,000 copy has been distributed so far. I mean, the Dorcas Cancer Foundation. Also, that's some of our programs that we've been able to do. I will be taking you through some other programs. Just because of time, we would quickly just move on now because our next speaker has joined us right now. So please let's welcome our next speaker, Dr. Uche Nwuku. Dr. Uche Nwuku is a member of the National Cancer Control Plan, NCCP, led by the Federal Ministry of Health in Nigeria. Please, let's welcome Dr. Uche. Good afternoon, sir.
Yeah, good afternoon, Korode. Good afternoon, everyone. I'm sorry for joining late. We had a series of other meetings in the ministry. That's why I couldn't join early enough. I also want to acknowledge I saw Her Excellency Dr. Zainab Shinkaba-Gudu in the room. Good afternoon, Your Excellency, man. And good afternoon, everyone else. I was asked to talk about the childhood cancers in the National Cancer Control Plan, the current and the future status. And just to say that the Federal Ministry of Health, in collaboration with all the stakeholders, including those in the room here, are working hard to implement the National Cancer Control Plan 2018 to 2022. In other words, the plan should be expiring this year. So the status might just be to look at what we have done since inception of the plan, and then what we plan to do, because we should be able to review the plan before the year ends. And then to state also that childhood cancers are very important to us, both as practitioners and to the government, for many reasons. One is the fact that childhood cancers are largely preventable, and the majority of the cases are incidentally curable. So that means any effort put towards addressing childhood cancers will be an effort in the right direction. So, and everyone should join hands together to ensure that we address childhood cancers in the country. Unfortunately, it's also on the increase. I'm sure the previous speakers may also talked about it. Childhood cancers are becoming more prevalent in our country, maybe because of improved capacity, because the government, excuse me, the government and of course various practitioners have also taken steps to improve capacity of our practitioners. Once there is improved capacity, have the relevant personnel, the diagnosis is made, and then many more of these women, parents may bring their children to the hospital, also due to increased awareness. Okay, so this may account for the recent surge in the number of cases that we have been seeing in the country across our cancer registries all over the country. Okay, so with the increase in the number of cancers among the children, it is only important that government should also place premium on what is done to address childhood cancers. Now, in the current plan, I guess everyone in the room here may have come across our National Cancer Control Plan. Is online, so anyone can download it and look at it. Now, the plan has 7 priority areas of action, which talks about prevention, awareness, prevention, diagnosis and treatment, supply chain management, hospital and palliative care, advocacy and social mobilization, data management and research, and of course, governance and finance. Okay, so these areas cut across all cancers, including childhood cancers. Okay, so government has taken steps to implement some of these priority areas, and the childhood cancers are not left out. The area that we have also placed a lot of emphasis is in the area of diagnosis and treatment. Like I said, we've noticed upsurge of childhood cancers in the country, probably because of improved capacity to diagnose and probably treat them. And that also has influenced people coming forward to bring their children to the hospitals for treatment. And that way, the data is captured. Okay, so we've improved capacity for diagnosis and treatment. With respect to the National Cancer Control Plan, we have about 8 activities that are meant to be addressed by the current Cancer Control Plan. And I can confidently say that out of the 8 activities that was meant to be achieved between 2018 and 2022, we have achieved 7 over 8, okay, which is a major, if you ask me, a major breakthrough. And some of those activities include establishment of Center of Excellence across the 6 geopolitical zones to manage cancers. There are centers that government have designated as centers of excellence. Those centers are just meant to provide comprehensive cancer care, including surgery, chemotherapy, radiotherapy, and other. And we know anyway that not all the centers have a full capacity to provide radiotherapy. For instance, some have linear accelerator, some have brachytherapy, some have both, but we are taking steps to ensure that these centers are up and running to provide all the services. Now, the other modality for cancer care, which is surgery, is also an area that we have taken a lot of interest. And as we speak, in the next in fact, 3rd and 4th of March, there's going to be a training of trainers of surgical oncology in Nigeria to ensure that our surgeons also have capacity, improved capacity to manage these patients. Now, in the area of the other activity that we are meant to address by the year 2020 is to improve access to quality cancer medicines. That we started in 2019, and at that time, in collaboration with China and the American Cancer Society, when we started, there was no formulations for pediatrics, but as at 2020, 2021, we already have formulations for pediatrics. We could ensure that childhood cancers are also adequately captured. Now, as part of the activity for this plan, the plan states that by the year 2020, we should have a functional patient navigation program in the country. And that also, in collaboration with China, we're also able to establish patient navigation, which is one of the activities in the cancer control plan. The only thing that was not achieved so far is to establish comprehensive subspecialty oncology training program at the postgraduate medical colleges. Even though we already have programs to train clinical and resident oncologists, but we do not yet have subspecialties like pediatric subspecialty, spiritual oncology subspecialty, gynecology subspecialty as programs in the colleges. So, and I'm sure that in no distant time or while we review this expiring plan, we have to take steps to address that only activity that is yet to be achieved in the current plan. Now, in the area of palliative care, the palliative care, as people may misunderstand it to be just for adults, which is not the case. It's meant to start even from the point of diagnosis and even to bereavement. So it's something that we have also developed a policy in the country to implement. Data management and research is also another very critical area in our cancer control plan. And like I said, we want to pick up more cases of childhood cancers, maybe because of improved effectiveness of our data management. One of the activities for that quality area in the plan is to have more cancer registries in the country, to train more data collectors, and to have to integrate our cancer registries in the national case registration systems for the country, HMIS. So which we're already taking steps to achieve. But of course, as we speak, we have over 33 cancer registries in Nigeria with 13 population-based cancer registries across the country. So what we're also trying to do is to ensure that pediatric cancers are appropriately captured into the cancer registries to ensure that we have enough information for policymaking and then activities to address childhood cancers. So in other words, I've tried to talk about the current status of childhood cancers in our cancer control plan. And then for the future, well, I need to announce that recently the National Assembly wrote the Federal Minister of Health to take steps to include childhood cancers as part of the cancer that should have free treatment in the country. That should gladden the heart of pediatric oncologists, and especially the Doctors Foundation and all those who are interested in childhood cancers in the country. Yes, but it is not as easy as it is stated in their letter. So what we're trying to do is that the country already has a cancer health fund where only 3 cancers were captured, which include breast, prostate, and cervical cancers. So what we're trying to do is to see if the budget line for that cancer health fund can be amended to accommodate childhood cancers. So that way, we can just enroll children into that platform to be able to have access to cancer treatment free of charge in the country. So that is for the future. Then as we also take steps to review the existing cancer control plan, hope that we'll place more emphasis on specific childhood cancers and see how we can also attract more attention and legislation in the implementation to ensure that we actualize the dream of having the children, whenever if cancer arises, while we try to stem the incidence, when the event that they arise, they should be able to have comprehensive treatment, which will confer them a lot of benefit by having them cured. Children have potentials to live longer than adults. So if you ask me, I would say if there's anyone who should have more opportunity to have cancer treatment, it should be the children, because they have longer life, if you put it that way, to live. So they need more attention. So in our subsequent plans and activities, will take steps to ensure that childhood cancers are adequately covered and implemented. Thank you so much.
Thank you very much, sir. Thank you very much for that wonderful speech talking about pediatric cancer in the current cancer control plan, the current status and the future. Please, I would like to let our audience know that, that you can send your questions. Please don't forget to send your questions to the Q&A space on the webinar platform. We're still going to be having the panel session where our speakers will be taking your questions, and then we'll be discussing these in a broader space. Please, you can ask questions, just send in your questions. We would be willing to take it. And before we move on, please, I would like to just appreciate everyone that has been with us since the beginning of this session. Thank you so much for your time. We have several people here, dignitaries. We cannot mention all your names, but thank you so much for taking your time to join this wonderful webinar from the Federal Ministry of Health, from the cancer advocacy groups. Thank you so much. And also from the Lagos State Ministry of Health. Thank you so much for joining and for being part of the International Childhood Cancer Day, and everyone that joined everywhere in the world. We really appreciate your presence. Now we're going to be moving on quickly, and then we'll be moving to our next speaker. Now, our next speaker now. Okay, we will be moving to our next speaker now. Okay. She is the programs manager, Cancer Access Program at the Clinton Access Health Initiative. Please join me to welcome Ms. Paulette Ibeka as she speaks on Pediatric Cancer Access Program in Nigeria. Good evening, Paulette.
Good evening, Korede. Thank you for the kind introduction, and good evening, good afternoon, good morning, everyone. Thank you so much for making the time to be at this webinar, and we hope that for everything that we share here, that you can learn about our work and also learn how you can play a role to really contribute to the support and improvement of health, of cancer outcomes in children. So who is CHI? For those who are on this call and do not know who the Clinton Health Access Initiative is, we are a global organization focused primarily on saving lives and reducing the burden of disease in low and middle income countries around the world. The goal is to really work with our governments to strengthen their commitment to improving the health of their citizens, and to work with private sector, to work closely with the ministries of health to create and sustain high quality health outcomes in all the countries where we work. And to date, Korede, can you please share the slides?
Oh, your slide. Apologies.
Yes, please.
Oh,
sorry about the delay.
Sorry about the delay. I think I'm finding it a bit. Okay. Oh, taking time to come up. Can you share from your end?
Sure.
Please. Apologies, please.
No worries. Thank you. All right, great. Thank you. If you can just wave, if you can see my screen, that would be great. So raise your hands. Yes. So again, who is CHI? So again, our focus is to save lives and to reduce the burden of disease, working very closely with our governments, and ensuring collaboration between the government and private sector players. CHI came into the public health space primarily to support countries with addressing the HIV/AIDS epidemic in 2002. And since then, we've ensured that over 84 countries have participated in CHI negotiated price reductions. What we see is that at the moment, we have over 140 global agreements with manufacturers of products, devices, and just generally providing the devices and commodities relevant for addressing health outcomes in low middle income countries. We have presence and role in over 30 countries, and with the strong and growing number of over 2,000 employees, which is CHAI's greatest asset. We work very hard to support our governments and to continuously work on achieving the ambitious goals we set to save lives. So this is a snapshot of where CHAI is, with about 10 of our countries playing or working very closely with their governments to address cancer care. So the CHAI strategy really focuses on the entire continuum of care, from prevention and screening to diagnosis, treatment, and to retention. What we have really focused on in the last since 2016 has been, that core strength that we have around market shaping for commodities, market shaping, which we started in the HIV/AIDS space, and we have extended to other disease areas, including maternal health and with vaccines. And so in 2016, in partnership with the American Cancer Society, we started to do work around improving access to anti-cancer medicines. And why is this important? Why are we also narrowing down to pediatric cancers after, just generally highlighting all cancers? Again, for most of you on the call who are healthcare providers, you would appreciate the fact that when we say cancer, we're not just talking about one disease, like when we talk about even HIV/AIDS or malaria. This is a disease that affects different organs in the body and different age groups. And so for pediatric cancer, this is really the impetus for our work. This is why we are working tirelessly to improve both the market access component and the system component of our work. Because what we see here is that in low middle income countries, less than a third of patients are even diagnosed, and when that happens, only about 29% survive. And so, when we bring it down to why is this happening, especially in terms of rate of treatments, retention, and completion, we see here that in a small baseline assessment conducted across 4 of the major tertiary facilities that provide pediatric care in Nigeria, we see that only Luth has about 84% completion rate. And it's safe to say that partnerships like the relationship between Luth and TDCF have a role to play in that high number. And so the question is, how do we replicate that across the country and across all centers that provide care for pediatric patients? Why is there this challenge? And this is where this is what our analysis showed, right? So when we came into the space, we did quite some engagements across countries. Again, in Nigeria, we engage our healthcare providers, the market players. And basically what it is that the low unpredictable volumes utilized in our country does not encourage the quality employers to dedicate availability of products that we need here. And so then what you have, again, is those quality products, they're very few and far available. And then you go back to that cycle again. Fortunately, this market failure can be reversed, and this is exactly what we're doing in partnership with the American Cancer Society, where we've been able to come to an agreement with 4 major manufacturers at the global level. But again, with the support of the Federal Ministry of Health, we have other manufacturers like Roche Diagnostics, who is not on the global access program, but have provided access prices to be on the Nigeria Cancer Access Partnership. And so as you see here, the typical approach in CHAI is to market shape for a number of countries. I mean, if you recall, we have presence in 30 countries, but over the years, more than the countries where we participate or where we have offices are benefiting from these market access deals that with support from our donors, we're able to set up. And so for the Cancer Access Partnership, We have over 27 countries, and fortunately, Nigeria is on that list. And so what has happened, over time, as Dr. Uche mentioned during his presentation, we started this work in 2017, where we announced the first agreement with 2 manufacturers, and with the engagement with the healthcare providers, some of which are on this call, we've been able to engage additional manufacturers, and we've gone from having no pediatric formulations to now having 50 formulations. And we trust that as we continue to engage, this will translate to more formulations, more therapies. So once upon a time in 2017, we only had chemotherapies, but now there are hormonal therapies, supportive therapies, and targeted therapies that are really useful. So what you see on this particular screen is all the products that are on the Cancer Access Partnership, a combination of both the adult and pediatric formulations. And I've highlighted pediatric formulations and also bolded the products that are currently available in country. So in other words, for all the healthcare providers here that provide services in the centers that are participating on the CAP, the products that are in bold, you can go to your pharmacy and fill that prescription for the patient, or encourage the patient to go to the pharmacy to fill that prescription. And for those centers that are not yet on the CAP, we welcome you to reach out to the Federal Ministry of Health to determine what are the steps you need to take. But in the next slide, I will quickly show how this plays out in Nigeria. And so again, just to walk us back to how CHAI operates, we work at the global level. Our colleagues at the global level engage the manufacturers, and through several mechanisms can agree on the number of products on the essential medicine, WHO essential medicines list, the number of products that are utilized for different cancers in country. And then with several negotiations can arrive at, or typically, and in our case, arrive at a value X works, right, at the factory level, that at the moment is usually anywhere from 50 to 60% less than what the actual prices are. And so if you see on the left-hand side, the schematic on the left-hand side shows us that, once the product is approved, by the manufacturer at the global level, then we have, in Nigerian context, the Federal Ministry of Health has played a fantastic and significant leadership role in ensuring that these products can come into the country by extended special import permits to manufacturers who don't have it yet, to then provide an opportunity for them to begin registration. So that regulatory bottleneck is removed. And then also, at the point of bringing it into the country, there is an agreement that the distributor sets up an access contract with the manufacturer, which then means that what the distributor is selling to ABUTH is exactly what the distributor is selling to AKTH, because this is a government-managed procurement system. And so also what we see is that the distributors have committed to ensuring the quality of the product, which was at the highest standard possible, because they are stringent regulatory authority approved. In other words, these products that you see on the Cancer Access Partnership Program are also products that are utilized in the US and in Europe to treat patients with the same cancers, right? Again, as the presentations have happened so far, we see that the NCCN harmonized guidelines are also utilized in country. So we see an adaptation of these guidelines that ensure that what is obtainable in Europe is also what's obtainable here, so that potentially we can start to see an improvement in our outcomes that are very similar. And so back to the schematic, once that distributor has those products available, they alert EMG Resources, who is the second private sector player in this program, who provides non-clinical solutions. And so basically what EMG Resources has done is that they've created an inventory management accounting system that not only helps patients log on to the platform to be able to get access to the treatment, but it also provides patients with a unique ID that allows them to fill their prescription at other participating centers should they be transferred there for services or find themselves in that location, for multiple reasons. And then the other solution this platform ensures is that it ensures immediate payment. And so what we see is that we no longer see a delay in the distributor or the manufacturer receiving funds associated to sales made. And so there also is no delay in replenishing products at the facility to ensure that when patients show up with a prescription that needs to be filled, they get their prescription filled. Overall, the benefits are, inventory and fund transparency that then translates to strengthening the system and aligning with the government healthcare system. We also see the markups being contained by the Federal Ministry of Health, who has been able to put a cap on what each player, each player in this system, we might see it and say, oh, but the distributor and EMG resources are also people in the space that were supposed to have been, eliminated as middlemen. But the truth is they provide a service that supports the system to work. But because of the Federal Ministry of Health's role, their markup is capped. And again, you don't see that variability in markup. So again, what the patient is paying in National Hospital Abuja is what they're also paying in ABUTH. So overall, we see that this program is scalable. We started with 7 centers and now we're at 14 and consistently growing and working to ensure that all public facilities and perhaps potentially private facilities can procure through the system or potentially see this being as the primary mechanism for procurement for anti-cancer medicine, such that quality is maintained, price is managed, and the patient receives the services they need where they are, the products they need where they are receiving services. So you don't have them traveling or searching and potentially not getting the right quality. And so we see that since the Cancer Access Partnership was launched in 2019, there has been some challenges with access for pediatric patients. And so what you see is a very small subset of this total number being pediatric patients. Again, we did not have that many formulations up until mid last year, so July 2021. But then as we look at this, I have a question for those of us on the call, and then just really looking to hear from everyone through the Q&A during the panel session to just chime in. I'm also looking to my fellow panelists to share how can we improve this? How can we start to see the large number of adult patients? Perhaps this goes back to Dr. Joseph's presentation, where she's flagging that a pediatric patient is at the mercy of their caregiver, right? What can we do to encourage the caregivers? Those are some of the thoughts, but I will also leave it to everyone on this call to please share with us, because this is a partnership. We do not know all the answers. We will continue to hear from you and make changes where relevant and truly invite everyone to support to improve outcomes for pediatric patients. And so for CHAI, we recognize that one part of this work is the access to quality, affordable medicines right where the patient receives services. But we also recognize that there are systematic challenges that affect this. And so in addition to all the supply chain work we do and working very closely with the National Cancer Control Program at the Ministry of Health to work on cancer control plans and treatment guidelines and all. We're also, as Dr. Uche mentioned, working closely with pilot facilities at this time to launch system strengthening approaches, specifically around patient navigation and providing educational materials, which again, we are so grateful for our relationship and partnership with the Dorcas Cancer Foundation, who's hosting us today, to just, again, help patients and caregivers remove the myth around cancer diagnosis for children, and to bring that hope that not only are these illnesses curable, but that the survivors can live to be productive members of our society. And so, as a snapshot, these are the centers where the Cancer Access Partnership are currently running. By no means is this a selection process, as much as it's a response to collaborative interest from the centers. In other words, this is a partnership. We will not insist that you join the CAP, but we really encourage participation, especially because of the value of meeting the needs of our patients and beginning to correct that figure, that graph that we saw, to start to see a change. So right now there's active participation across 12 facilities, but over 13 have been activated. But we see activity across 12, and we will be working with some of the centers already activated to identify what the challenges are and to improve them. We have earmarked a number of centers, but again, I call on those on the call, the state's tertiary facilities, other public tertiary facilities, to work with the Federal Ministry of Health, and we are more than happy to provide the support to ensure that the Cancer Access Partnership is available at your center and providing the support that you need to achieve your work. Because through your hands, or through our hands, is with all of us, ensuring that what we need is available and that we can meet the needs of our patients. And so what are the next steps? Again, we will continue to work with you, just like we went from 0 to 15 formulations for children. We really want to see all the WHO essential medicines listed for treatment of childhood cancers available on the portfolio, not just at the global level, but in country. We will continue to coordinate and consolidate procurement, not just with the 14 centers, but with the aim of expanding to anywhere a cancer patient is seen, primarily anywhere a child will go in to receive cancer services. As Dr. Uche has mentioned in his presentation, we will continue to identify and support the government to identify financing mechanisms and to strengthen ways that we can start to provide succor. There was a question already in the Q&A around what the government was doing to provide support for any family that has a relative, a member diagnosed with cancer in Nigeria, has a very high odds of becoming bankrupt or not being able to pay. But what's up for children, like Dr. Joseph mentioned in the video, is that who makes that decision to sell a plot of land? Who makes that decision to businesses or property to raise funds for the child's treatments? Not them, right? And so what do we start to do to support parents who can, but more so ensure that parents who cannot get services for their patients, and also start to move to that place where there's no reason if a family should be worried about bankruptcy because of a diagnosis of cancer with the child. We also want to identify mechanisms to strengthen approaches that already exist. I'm looking forward to Dr. Shaya's presentation, because I anticipate is going to share a bit more about the details being done. The work being done by TDCF, but to increase the index of suspicion amongst nurses, amongst CHUs, amongst doctors, to say, this child has come in too many times for malaria and typhoid. Let's refer them to LUTH. Let's refer them to National Hospital so they get that diagnosis and commence treatment early, such that they can still contribute to the society. So thank you so much, everyone. I look forward to our discussion session and happy to answer questions and potentially point us to the right direction if I can. Thank you very much.
And thank you so much, Paulette, for that wonderful presentation. Thank you so much. Thank you. Thank you. I'm sure, I mean, the chat room is buzzing now. And so please don't forget to send your questions on the question and answer space so that we can easily track it on the question and answer space. And please, for access to sessions of videos, please sign up to our newsletter via www.tdcf.ng. And you can also subscribe to our YouTube page. The link has been shared on the chat room, so you can check there to see. There are so many people asking that, okay, how can they get more information? You can just follow us on all our social space, our social media. On Instagram, it's the Dorcas Cancer Foundation. On LinkedIn, it's the Dorcas Cancer Foundation. On Facebook, the Dorcas Cancer Foundation. On Twitter, Dorcas Cancer. And even on YouTube, the Dorcas Cancer Foundation. There you can have access to programs, informations, and learning materials that would really help you. Thank you so much, Paulette, once again. Now, before we go to the next speaker, I would like to use this opportunity to also appreciate everyone once again. And these wonderful people that have been here, the nurses, these wonderful people doing the job, they are here. We have quite a lot of nurses here. Please, I have a special clap for the nurses to just appreciate every one of them taking their time to join. These are for the nurses. Thank you so much. And in the same vein, I appreciate everybody, the doctors, the advocates, everyone that is here. Thank you so much for your patience. Now, before I bring in our next speaker, I just quickly want to show us one of the good news from the Dorcas Cancer Foundation. One of I will use the word testimony, a survivor, to show that children do survive cancer. And then please join me as I welcome the father of one of our kids, Mr. Ifeanyi Odo.
Good afternoon, everyone. It's a pleasure being in your midst this beautiful afternoon. Thank you for the opportunity. Thank you for the opportunity and the privilege to be in your midst this afternoon. And I must say again, thank you to the Dorcas Cancer Foundation and the entire team. My name is Ifeanyi Precious Odo. I'm the father to Perfect Osahumese Odo, who was diagnosed of retinoblastoma at the age of 3. By the special grace of God, as one of the speakers mentioned earlier, that one of the major advantages of survival is early detection. We so much thank God Almighty for the privilege given to us to go through the journey. And I must say critically that the journey is actually not easy. At the picture there, you can see myself and my son Perfect. Currently, he's wearing an artificial eye on the left eye. By the grace of God, the right eye is still safe and free. The journey started in March 29, 2018, when something that looks like a crystal was observed on his left eye. So I came back and it was just like a simple thing. We went to the first eye clinic where the doctor said it was something that looks like cataract. Unfortunately, she said she cannot handle it, and we were referred to another hospital in Agege, St. Cecilia Catholic Eye Hospital in Agege. So from there, there was another confirmation. That was the first place the issue of retinoblastoma was mentioned to my hearing as a human being. I've not heard about that word before. So it was from there they referred us to LUT. Getting to LUT did their test and everything. Retinoblastoma was confirmed. But LUT wanted to be too sure, and they referred us to St. Edmunds in Surulere. Getting to St. Edmund in Surulere, finally, retinoblastoma was actually confirmed. And looking at it from that perspective, what is the next stage? I so much thank God for his leadings. This is where I will also appeal to so many people who take religion to more than medicine. When cancer is diagnosed, instead of following the medical aspect, so we'll be telling you to be going on 7 days dry fasting and prayer, that the cancer will go. Honestly, I believe in prayers, I believe in God, I believe in healing, I believe in miracles. But at times, we should also take some medications seriously. To God be the glory. We started with the first dose of the chemotherapy there in the oncology, pediatric oncology ward in Lut. It was there and then somebody introduced us to the Dorcas Cancer Foundation. I must also use this opportunity to the CEO or the MD of the Dorcas Cancer Foundation for the good job she's doing. And I will also plead that we need to do more, because a whole lot of children are dying out there on a daily basis. This thing called cancer. So as far as we are concerned, we are thanking God Almighty for the healing. From the first treatment, that was how we went into the second treatment, the third, the fourth. From that fourth, we were referred to National Hospital, Abuja, to go and continue with the radiotherapy. I must say that the stage and the process of radiotherapy in Nigeria then wasn't that easy at all. A whole lot of things need to be put in place for us to record more survival ratio when it comes to cancer generally, not only pediatric this time. But I must also say that our journey to Abuja at the National Hospital wasn't that easy, but above all, he was able to get about 34 exposures of radiotherapy over there in National Hospital. Huge sum amount of money paid for a child and all that. At the end, we came back again to Lut to continue with the chemotherapy, the 5th and the 6th stage of chemotherapy. We tried all these things, all we ended up in praise. One of the saddest days I have ever had in my life is hearing that your child had cancer. And another thing we are also thanking God for is everything actually has an end. The cancer was diagnosed one day, and a day also came where after several tests and analysis, we were referred for MRI, magnetic resonance imaging scan, over there in St. Edmund. So by the special grace of God, it ended well, and they said he has no traces of cancer anymore. I must also tell both the participants, the delegate, and others that as we speak now, my son is back to school. I thank God Almighty. I so much thank the Dorcas Cancer Foundation for the wonderful role they played. In fact, words are not even enough for me to appreciate them. And I still believe that as God keeps us alive, we have enough to say thank you to the Dorcas Cancer Foundation. I remember the days of running several tests in the lab, and the money wasn't there, and these guys took up this boy as if he was their child. Honestly, I say again, thank you to the Dorcas Cancer Foundation for the wonderful job you guys are doing. Please, there is still need for you to do more, because I sincerely believe that there are a whole lot of children out there. Even this morning, I was coming to work, I saw 2 children over there in mine too, begging for alms. And when I look at their eyes, oh my God, I said, wow, this was what I noticed in 2018. when that of my child started. But as a result of ignorance or one or two reasons, these guys are out of the hospital. They are in bus stores begging money from January to December, and the condition keep worsening on a daily basis. Then the government on their own, I call on them to also do their best as much as we are concerned. A whole lot of children are dying of childhood cancer, and the government seems not to be interested. Another thing I will also discuss here, where I think we can also look at again, is the idea of sedating children before taking radiotherapy, because the 31st shot that my son took on a daily basis, just for him to be able to sit on a one place, they must put him to sleep, which I also think, although I'm not a medical doctor, which I also think that most of these things, putting these chemicals on the children to make them go to sleep, for them to be able to take this radiotherapy, might also have a side effect. For 1 year, hair never came out from my child's head, and I was a bit scared. The spot on the left eye, where although most of those things are beginning to clean off now, the color changed. On a daily basis, I keep wondering, when will the hair come back again? But as we speak now, he's back to school, he's sound, he's healthy, and all that. Though I know that he is wearing an artificial eye, but he is far, 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 far better than those who lost their eyes completely, or also who lost their life as a result to childhood cancer. All participants, please join me in saying thank you to the Docas Cancer Foundation. They are wonderful. They are wonderful. Thank you so much. These are one of the things which we experienced then, and which I thank God that affliction will never rise again by the special grace of God. We are still managing the right eye. We are still trusting God that on a regular basis, since that 2018 till now, we are still in Lutz, visiting both the oncology and the Guinness Eye Center to always carry out screen the right eye to ensure that the boy grows with his eye and all that. So for the sake of time, because I know that people are still waiting, if you have any question on how you think or how we went through it and all that, I'm still available to entertain some of your questions. Thank you so much for this opportunity. Thank you for the privilege to be part of this webinar. Thank you for contacting us. As I said earlier, we will always be available to share good testimonies as far as cancer treatment is concerned. I could also remember when Punch visited us to also find out a 3-year-old child had cancer and survived. I said, yes, it is possible. So my son is a living testimony. By the grace of God, he's doing pretty good. Thank you so much for this opportunity.
Okay, thank you very, very much, sir. Thank you for sharing. Thank you for taking your time to share your story. Thank you so much. So quickly, because of time, we'll be moving on. Like you said, I mean, it's still very much around. If you have any question, please use the Q&A session, and some of our questions, some of your questions will be given answers to. So for some of us that has dropped questions at the Q&A session, you can just see some of the answers, so that because of time quickly. So we need to quickly now move on now. And please don't let us forget, you can also just check the chat. There are so many information coming through the chat space also that will benefit everyone here. So we are moving on to the next speaker now, quickly because of time. Our next speaker is Mrs. Dorcas Shonibare. Mrs. Dorcas Shonibare is our next speaker. Mrs. Dorcas Shonibare, she is the Director, Nursing Services, Lagos State Ministry of Health. Please let's welcome Mrs. Shonibare Dorcas Olukemi Oluyemisi. Good evening, ma. Thank you so much for your time, ma.
Good evening, everybody.
Good evening.
Good evening. I believe right there you are going to share the slides.
Yes.
Okay. Appreciation, I want to really appreciate the Dorcas Cancer Foundation. When I got the letter, and it has to do with pediatrics, I became emotional about the topic. But we appreciate you. Federal Ministry of Health and Clinton Health Access Initiative for the opportunity to bring up a webinar of this nature. I want to acknowledge the presence of Your Excellency, the First Lady of Kebbi State, Dr. Mrs. Zainab Bagudu, panelists, co-presenters, and the audience. Thank you for staying on up till this time. And I want to also congratulate Mr. Ifeanyi Odo, father of a survivor. That was a great testimony. So let's move on with the presentation. The role of nurses in enhancing the outcome of pediatric cancer in Nigeria. Let's move on. Next slide. My next slide talks about, it's an introduction. It says, what is cancer? And that is for the lay people that may still be on this webinar this afternoon. It's a disease condition in which abnormal body cells divide uncontrollably and destroy body tissues. Thank God for Mr. Ifeanyi, who was able to identify that the cells in the eye of his son was growing and something needed to be done. And so apart from body cells, it can destroy organs and a whole system of a human being, especially children, on whom we are focusing today. So Professor listed all the various types of childhood cancers. So we'll move on from there. I don't need to go through that. Then people often ask, next slide, people usually ask the following questions. Can a child get cancer disease? What causes cancer in children? What is the common age for childhood cancer? Please move on to the next slide, Korede. What is the most common age for childhood cancer? So many questions, which some of them have been answered this afternoon. And I will say from my own slide here, next slide, what is childhood cancer? Childhood cancer is not just one disease. There are more than 12 major types of pediatric cancers and over 100 subtypes. Let's move on. The theme for year 2022, World Cancer Day, which was February 6th, is closing the care gap. Cancer occurs more frequently in adolescents and young adults, age 15 to 39. 15 to 39 years than in younger children, although incidence in this group is still much lower than in older adults. But children are too young for any unhealthy habits to increase the risk of cancer. A strong family history of cancer may increase a child's risk of cancer, but these genes are extremely rare. Childhood cancer are almost caused by a DNA mutation that is not inherited, but just happened or acquired randomly. Now, what is the role of nurses in enhancing the outcome of pediatric cancer in Nigeria? You know, with all that is happening in the health sector, I will want to briefly define who is a nurse. According to National Council of Nursing, ICN, a nurse is a male or female person who has completed a basic general nursing education in an accredited school or university by the Nursing and Midwifery Council in his or her country. This individual must be duly registered to practice evidence of a valid license in any part of the world. So nurses trained in Nigeria must possess an evidence of a valid license authorized by the Nursing and Midwifery Council of Nigeria, NMCN. Now, why do I need to define who is a nurse? Because there are many out there who call themselves nurses and they are not. And rather than assisting us to identify these children in good time for management, they keep giving them what they don't know, and only to complicate the matters at hand. That majority of the problems we have in the health sector that adds to mortality is the fact that majority of our people are being attended to by these quacks. And by the time they are now being referred to health facilities, it's almost at a time that is too late for any miracle to occur. So the nursing profession is a heartbeat of the healthcare system. And we have, is the heartbeat of the healthcare system. And we have several specialties, which has to do with pediatric nursing, because we are talking about pediatrics now. And we have oncology nursing as well. Though this oncology nursing is not yet part of the program we run in Nigeria, but outside the country, in developed countries, they have oncology nursing. We have critical care nursing, maternal and child health, medical surgical nursing, community health nursing, mental health / psychiatric nursing, orthopedics, perioperative, ophthalmic nursing, just name them. These are the various specialties whereby a nurse can make impact in the life of a child that may have cancer. Now, cancer in children is a traumatic experience for the child, for the pediatric nurse, for the physician, for the oncology nurse, for the parents and family members. So the child finds it difficult to express exactly how he or she feels, except through crying and being restless, especially when the concerned mother or father is not observant. Thank God for an observant father like Mr. Ifeanyi Odo. Now, what are still the role of nurses in enhancing the outcome of pediatric cancer in Nigeria? A professional nurse has diverse roles to play in pediatric cancer. A pediatric nurse or an oncology nurse is a caregiver and is expected to be a confidant to the patient. And in this case, we are talking about pediatrics. A nurse should be a confidant to the parents of this child and be able to give them updated information that is expected for these parents to be carried along in the care of their child. There should be a pediatric nurse or a nurse caring for a child with cancer should be a good communicator. You should be able to create awareness. You must be able to advocate for the care of these children. During the presentation by the Federal Ministry of Health official, I was happy to hear that the House of Assembly has put it into documentation that pediatric patients with cancer should be able to have free health care service. We pray it becomes implemented in good time. So these are some of the awareness that we can create to help our patients. Now, apart from creating awareness, a nurse, a teacher, a client advocate, a counselor, a change agent, do research. We also mentioned the aspect of how many of these cancer that we have in our children in Nigeria is being captured in the database. So the nurse can also assist. By the time we know how many of these cases that we have, they'll be able to make a strategic plan to reach out to these children. Now, what is still the role of nurses? It has to do with basic assessment through the use of Gordon typology. Through the Gordon typology and the model of care adopted in the health facility. So Gordon's typology helps to assess the situation of the child and to be able to know, as a professional nurse, what should be the next thing? What information do I have for the pediatrician? What information do I have for the oncologist? And the physiological health of the child is very, very paramount. Preventive care to all these patients, treatment activities, pain management, the nutrition of a child that is having cancer is very critical. Circulation, fluid and electrolytes, acid-base balance, oxygenation, fecal and urinary elimination. These are physiological health aspects that a nurse should be able to be concerned about in a child with cancer. Psychosocial health of the child, the sensory perception, self-concept of the child and that of the parent, sexuality, spirituality. Mr. Ifeanyi was able to mention the aspect of some people believing that they can do fasting, and God gave us medical knowledge and it must be accessible to the people. Stress and coping, loss, grieving and death. We don't pray for any of them to die. We look forward to them to survive. Psychological care of the patient is very, very paramount at a time like this. So the psychological homeostasis of the parents, especially homeostasis of the patient, of the parents, especially the mother, is critical. But we only see a father of a survivor today. So it's very critical. Such is emotional or psychological balance. Because when the parents are psychologically balanced, then they will be able to know what next to do and not just to abandon the child to the situation at hand. Yes, because of time, let me summarize by saying that the nurses have critical role to play to make the reduction of, to increase the survival rate of children with cancer. Nursing is a profession that is unique and is broad. Essential services required where humans exist. When nursing care and services are effectively carried out in a conducive environment, it leads to positive health outcomes with patient satisfaction at the core of care. So nursing roles, though not celebrated by most people, are very pivotal in achieving the best results in the health sector. Therefore, please ask for the license of that nurse caring for you or for your child to avoid disaster of a quack. And I believe all nurses that are here today on this webinar, they are pledging their support to continually collaborate with the Dorcas Cancer Foundation for us to increase the survival rate of children with cancer in Nigeria. Thank you very much for the opportunity to discuss with you. Thank you very much.
Thank you so much, ma'am, for that wonderful presentation. Thank you very much. Thank you so much. And we too at the Dorcas Cancer Foundation, our hands are open to collaborate with all the nurses so as to improve pediatric cancer outcome in Nigeria and in Lagos State. Thank you very much, ma'am. Please let's know that we still have a panel session. All our speakers are still much around. Please, we won't take much of your time. So your questions, please put your questions in the Q&A sessions. All your questions would be answered. So we'll be going to the last speaker for the presentation, and then we move on. From there, we'll move to the Q&A session. Thank you so much once again, Mrs. Dorcas Shonibare. Yeah. Okay.
Thank you.
Thank you, ma'am. Okay, our last speaker is Dr. Adesheye Akinshete. He is a consultant hemato-oncologist at the Lagos University Teaching Hospital, LUTH, and he's going to be speaking on the tales of two cities. Please let's welcome Dr. Adesheye Akeshete. Good evening, sir. You are muted, sir.
Good evening, everyone.
Good evening, sir.
Can I just share my screen so that I will run through what I have to talk about?
Yes, yes, sir.
I'm still disabled.
You're still disabled.
Okay, so Your Excellency, good evening, ma'am. It's a pleasure to have you on the call. Other panelists, thank you for your time and good evening to you all and to all those who are attending today. Over the next 10 to 12 minutes, I'll be talking about, I'm supposed to talk about a tale of two cities where I would look at cancer outcomes in a resource-endowed nation and compare and contrast it with what we have in Nigeria. So I'll be talking about opportunities for innovation, a tale of two cities. Excuse me. So this will be the outline. We've talked about burden and what incidence is globally. Professor Alan Davidson spent quite a bit of time taking us through how many cases we see in different regions of the world. With regards to Nigeria, we do not have each standardized incidence rates, and it's because we don't have any population-based pediatric cancer registry. Dr. Uche talked about us having 13 population-based registries, but most of them cater for adult oncology cases, and very rarely do you find significant data on children. Hopefully, before the first half of the year runs out, we should be able to launch a fully pediatric-based cancer registry that we will start from a small locality and then hope that we will collaborate and move to other regions. So the new estimates from the WHO released at the end of 2021 showed that there were over 400,000 cases of pediatric cancers last year, which is a far cry from what Dr. Stelionova had predicted by models year in, year out. I mean, she talks about cases in the range of 185 to 200,000, but the new WHO estimates talk about 400,000. So what it means is that we're making better diagnoses, but we need it to translate to better outcomes. So with regard to survival, I mean, we also saw what Professor Alan Davidson shared, where he talked about survival across different regions, and expectedly survival was better in parts of the world with better resources. However, a paper was published in 2019 by Professor Lonarena in Ghana, and that paper showed that survival is not tied to high cost or high expense. Survival is actually tied to a robust system that is self-innovating and progressive. So I'll try and share some of these thoughts as we move along. So our first publication in Nigeria with regards to childhood cancers was in 1975, and it was a summary of the then Ibadan Cancer Registry. And we had the outlay of the cancers, majorly lymphomas and some other types of solid tumors. That registry publication did not talk about leukemias. Now, when we look over the years, the trends that have also been published in different parts of Nigeria, Uyo through Kano to Kaduna, showed that we were seeing more of solid tumors and we were not seeing leukemias, as opposed to when you look at what you find in other parts of the world. Now, what we have in our series that have been published in Nigeria is similar to what, two population-based cancer registries in Africa have put forward. So the Harare Cancer Registry talked about the prevalence of lymphomas, predominantly Burkitt's and Kaposi sarcoma, as the most common cancer types they were seeing. That was a report published last year, December. And then the Ugandan Cancer Registry, publishing out of Kiamondo in Kampala, also talked about lymphomas, Burkitt's, and Kaposi sarcoma. But when we looked at our records in Lagos and we tried to see what we had looked at, and hopefully we're updating that this year, we found that we were seeing more leukemias and lymphomas were not common. In fact, the percentage of Burkitt's we saw in Lagos over a 3-year period was 3%, which was a far cry from the reports from other parts of the country. So this establishes a need for a robust population cancer-based registry, which would actually answer the real questions and not the hospital-based questions. So let's look at what's the landscape. So we're talking about improving our outcomes when we approach the problem as physicians. So we published in 2019 and we've updated the register as at 2022 January to see how many pediatric oncologists are in Nigeria. Prior to now, we had 42. Now we have new trainees who are joining. Unfortunately, of the 42 we had before, we have lost 6 to brain drain. So what you find is that Nigeria, there's a new problem. There's a leaking problem we have. We're losing experts who have spent quite a bit of time gaining knowledge. Now we're replacing them with younger specialists. And so what it means is that it would impact on our mortality rates and on our survival outcomes. So that's one problem. As at 2019, we only had 2 pediatric oncology wards in Nigeria. As at 2022, the story is the same. So in the space of when we published over 3 years and data that we gathered over 3 years, over the last 6 years, we haven't moved with regards population having dedicated pediatric oncology wards. So what we mean by this is that for us to improve outcomes, we need to keep all the children who have cancers in one place. We need to ensure that the nurses who treat them are nurses who only treat children with cancers. We need to ensure that the pharmacists who are there are those who attend to children with cancers. It's a tall order, but it's an achievable thing, and it's a low-cost initiative. Now, I've talked about no registry. From when we gathered our data in 2015 till today, 2022, a period of 7 years, Nigeria still does not have defined, definite molecular diagnostic capacity. So what it means is that we can't subspeciate the tumors that we see. So we get the tumors to the laboratory, the pathologist will look at it and tell us it's a small round blue cell tumor. But that does not speak to pediatric oncology because there is a wide variety of small round blue cell tumors. We can't type them in Nigeria as we speak, 7 years after we gathered data and we published. So there is something that is wrong. Nigeria, a country of approximately 200 people, several tertiary institutions, we do not have capacity to do flow cytometry, and that's not good enough. So all of those things mean that the kids will slip out of our hands and they will slip through. Now, 4 years after we published our initial manuscript, we still do not have formal care pathways in Nigeria, and that's a huge problem. And then coupled on that, I looked at the wards where we manage our patients. We've been able to keep our nurses for the last 3 years, but over the last 6 to 9 months, we have lost 3 nurses. As I'm talking to you this evening, 3 of our nurses are at different stages of emigrating out. So when we begin to lose critical resource, like our nursing resource, then there's a huge problem that we have to deal with. And all of these are low-hanging fruits that we can deal with so that we can improve outcome. So what are the challenges? I mean, we all know what challenges will be, but the way I like to look at things are that what are the problems that can be fixed in the short term, in the medium term, and in the long term? Because ultimately, we're going to get the figures to be better. We're going to get good survival statistics in Nigeria. It's just going to be a matter of time, but we want to make it as short as possible. So we published a manuscript last year, and we found that it took 15 weeks, averagely, for a child to present at any healthcare facility and a diagnosis is made. However, it took 39 weeks from when that diagnosis is made before the child gets to a specialist. So by the time they get to specialists, what it shows is the disease has progressed. So it's not enough for us to think that because I'm a doctor, because I'm a nurse, because I'm a pharmacist, we all have knowledge. That's not true. The evidence from what we were able to gather from our data shows that our knowledge base is abysmal. So that's a problem for us. We also found out that there was no synergy, and it was the lack of synergy that made our kids spend 39 weeks looking from one general hospital to the other, from one private hospital to the other, seeking care, because there was no synergy in the system. Hopefully, CHAI is going to be able to help us fix the problem of drugs. And we hope that more and more teaching hospitals will get on board, and then we'll be able to speak one language and be able to bring cancer care closer to the kids. However, fixing accessibility to medications is one arm of it. The other arm is, how do we get the funding for these individuals? We also have a paper where we looked at what was the average cost of treating cancers in Nigeria. And we found that over 90% of parents pay out of pocket for cancer care. So what it means is that 90% of Nigerians are one cancer away from bankruptcy. That's a huge problem. Palliative care, hopefully things are being done to strengthen that place. So what do we really want to do? I mean, we've talked about, we know where the problems are. What are the low-hanging fruit? So the first thing for us is that we must focus our manpower development. And we need to be innovative about how we will get our healthcare personnel to stay within the landscape. It's something that government can do. It's something that heads of institutions can do. It's something that people like Dorcas can do. So we need to get training opportunities for our healthcare personnel. We need to get them to see how it's done in better climes. We need to bond them. I mean, I have no apologies about that. The nation cannot spend money to train someone, and then the person comes back and decides to ship that knowledge to the UK. I think that that's criminal and it's not acceptable. So if Nigeria is training somebody, then Nigeria has a responsibility to bond that person, that for the next 3 years, you will train people, you will put what you learned to some people. So we need to do that, and we need to do it fast. It's low cost. There are different places across the globe. There are different foundations, there are different scholarships where we can do manpower development. Then we need to develop manpower locally. It's not everything that has to go abroad. So if Kanu has the ability to train people robustly in the management of Burkitt's lymphoma, then people should send to Kanu. If Enugu has the ability to do the same, then people should go to Enugu. So we need to look at that. We need to get a focused and pragmatic insurance policy that will help us move the standard of care and move the needle of outcomes. We need to develop multidisciplinary teams. Working in silos will not help us again. We have to understand that except we have multidisciplinary teams, we can't improve our outcomes. So that this oncology care is not a care where there is a disconnect between the physician and the nurses, between the nurses and the dietitians. Everybody comes and sits. I think it is criminal. Yes, we're all on this call now. There are nurses, there are doctors on this call, but the disconnect is huge. I don't live in a matrix. The nurses have to understand that there is nothing like, oh, it's the doctor's patient. There's no doctor's patient. It's our patient. The patient is the center of our universe. So we need to do that. We need to develop our nursing care plans to meet up with our physician care plan so that it is one care plan for the patients. We also need to ensure that it's not everybody that will treat childhood cancers because it's economies of scale. Evidence has shown that a center that treats 500 will do better than a center that treats 30. So we need to put things together and get it going. We need to develop local research that will answer specific problems for our specific populations and find local solutions to ensure that we move the hand of the needle. So finally, if we look at the two cities, so I'll just look at, it's a story that I'm sure we're all familiar with, Charles Dickens, when he talked about A Tale of Two Cities. So Mary is an 8-year-old girl, and she has newly diagnosed acute lymphoblastic leukemia. She's been seen by our primary care doctors, so our private hospital doctors, and they've decided that Mary needs a specialist attention. Now, Mary's parents are both teachers in the town's secondary school. So we can assume hypothetically that Mary is a girl who lives in Funtua. Mary is a girl who lives in Nnewi. Mary is a girl who lives in Ogbomosho. Mary is a girl who lives in Ikotekpene. So our parents are that historical Nigerian middle class family. So let's look at Mary's story. So if Mary were in any of those places, Ikotekpene, Funtua, Potiskum, Kafanchan, Nnewi, Ekulobia, any of those places, it would take the system 3 to 4 weeks to make a diagnosis. However, as you move away from the center, the time to diagnosis increases. So it will take them maybe 4 weeks in Lagos. It will take them maybe 4 weeks in Kano. If you move away from that radius, then time to diagnosis increases. Now, Mary's treatment will start 4 to 5 weeks after diagnosis because the parents have to go and source for her funds. Halfway through Mary's treatment, her parents are bankrupt. And it's our experience, it's what we see in our practice in Lagos. And that's why we then developed the strategic partnership of what is done in every other part of the world. Every high-performing pediatric cancer institute has a high-performing cancer NGO that works with them. So while they focus on the science of getting the kids to be better, that NGO focuses on getting them 3rd, 4th, 5th generation funding for them to ensure that the children survive. It's of no use to the children I see if I have all the knowledge in the world and it doesn't translate to outcomes. It's useless. So they will be bankrupt, but we need to fix that. There is no insurance, we've said that. Now there's a 15% chance with all the best of support that Mary will survive. Mary's concern and the concern of her parents are that, will she be alive after the diagnosis? So now let's travel down 6 hours by plane to London. And this London is regardless of where. So London, Coventry, Birmingham, Newcastle upon Tyne, Shrewsbury, wherever in the United Kingdom, even up to the far isles of Carrington Island. The system makes a diagnosis in 48 hours if she's in London. If she's in the farthest part of, let's assume hypothetically, Isle of Man, it's going to take them maximum 72.6 hours for them to make the diagnosis of Mary. And our treatment will start once our diagnosis is made. Our parents do not care about where do we get money to fund Mary's care. No, they are paying their taxes, and their taxes, a part of it is going to the King's Fund, and a part of the King's Fund is funding Mary's care, at least a basic care that will ensure that she goes flawlessly through this. When Mary's parents come to the hospital, they are not bothered about how to pay admission deposit. So what are they bothered about? How to ensure that their life goes on while Mary's care. There's a strong community and social support for Mary. The hospital provides her support, the local government provides her support, the community provides her support. And there's a 90% chance that she will survive. So what will be Mary's concern? Mary's concern is that she will lose her hair because you've told her at counseling that, look, when you take chemotherapeutic agents, there's a chance that you lose your hair. So what, in conclusion, are the things we need to look at? We need to know that we can improve outcomes. And definitely we can do it. It's just for us to sit down, form a community, determine what the common problems are, and determine low-cost solutions on how to solve the common problem. Technology has made that easier for us. So I can sit in my consulting room and assist my colleague who is in the farthest part of the country if he needs a resource that I have. We can improve time to diagnosis, and that will involve what Dorcas is already doing with their Look Again campaign. There is no reason for a physician to feel that he knows it when he has no clue about what is happening. Just move the patient to a specific place. Don't say, go to a general hospital. No, pick yourself, go to this teaching hospital. They'll be able to help you. What we are doing now is that rather than wait for that, we are getting phone lines. Dorcas is going to provide that. And we're going to share those phone numbers with all the hospitals around us in Lagos and Ogun State. You have a child that looks like that child has a cancer, just call us. Once you ring us, we will assist you and we'll find a way to get that particular child to receive care. Improved community knowledge and participation is what that is key. I'm not against prayers, against pastors and imams. They are a necessity. They are a present part of our national life now. So we need to find a way to incorporate them into how we will improve outcomes. We need to understand that they have significant mileage and parents respect them. So we have to get them to sit comfortably in our care plan so that we can get better outcomes. Health insurance, if we can get that, it will be so sweet, because what it then means is that parents will be quick to come to the hospital. They'll be quick to want to bring their kids to us because they know that once they come in, they don't need to crack their head. They don't need to go sell their cars. They don't need to sell their shops. They don't need to do anything that is catastrophic for their kids to get here. And it's a possible thing. And we hope that all the excess and the extra innovations that the ministry is bringing out, I'm begging Dr. Uche, they should begin to think of children. We don't want to be the forgotten ones that at the conversation when decisions have been made, then people say, oh, we need to think about children. That's not what we want. We want to be at the center of the table when we're discussing breast, colon, cervix, and all of those other ones. And finally, we will try to develop care pathways. We will try to plead with our physicians, our seniors, and our colleagues that can we bring down the ego a bit so that we form a community and we move forward, because it is better the whole of Nigeria is at 70% than for one part of Nigeria to be at 85 and another part of Nigeria to be at 15. Then we have failed collectively as a person. So thank you very much for having me. And I hope that this will stimulate us to have further discussion. Thank you very much.
Okay, thank you very much, sir, for that wonderful presentation. Thank you so much for that. That was very, very enlightening. Thank you very much, sir. And once again, now we've come to the final session of this webinar, which is the panel session. And now I would be bringing our panelists on board. They've been wonderful. I mean, now it's time to give answers to your questions. I've seen some questions coming in, so we would be taking this question one after the other now. Sir, you can, okay. Can you stop sharing, sir? Okay. Okay.
Just give me a minute. Let me stop sharing. Sorry. I've stopped.
Okay, yes, I can see that now. All right, thank you so much, for once again for that wonderful presentation. Now it's time to bring all our panelists. So please, I want all our panelists to please just unmute their mics so as we direct the questions to them one after the other. Thank you so much, Our Excellency Dr. Mrs. Zainab Shinkafi Bagudu. Thank you so much for your time. Thank you for your patience with us since And also, thank you so much, Mrs. Shonibare Dokas Olukemi EMC, for your time. Thank you for your presentation. Thank you so much, Dr. Uche, for your time. So thank you so much, Paulette, for your time. So we'll be taking the question now. So the first question, all questions that I asked are relevant, but because of time, we have to take it one. So I will be giving the first question to Our Excellency, Dr. Bagudu. Now, there's a question someone asked here. He said, how will a patient in the rural area be reached? That she was just, I mean, the person is talking about a majority are on the road seeking but for how long? Mobilization, how long will mobilization get to them? So I think the person is trying to ask the question that what can we do to reach out to the rural community? Okay, hello? Hello, ma? Okay, I think, hello, ma? Okay, I think Our Excellency is not on seat right now. So let me see if I can direct that question to one of our speakers. Dr. Akinshete, sir, would you like to answer that question, or Dr. Uche? Sir?
I think Dr. Uche will be able to answer. It's more a systems thing.
Yes. Dr. Uche, sir. Okay. I think maybe any of our other of our panelists. Paulette, you want to help? I think Dr. Uche, Dr. Zainab is not, Her Excellency is not there right now.
Can you recap the question?
Okay, now the question is, the person is trying to know, how do we get the rural community involved? Said, okay, most of these rural patients are someone in Kinshafa, someone very far in the southwest and the north, who are not, I mean, aware of information. What can we do to get them informed, to get them mobilized and sensitized about childhood cancer?
So thank you. I think that we need to, for me, we need to take it one step at a time. Those of the people who are in the urban areas are not even properly, they don't have the right kind of knowledge about childhood cancers. So I think if we can first get the people at the city centers and the peri-urban areas to understand what childhood cancers are and how to approach them, I think over time, we will then be able to figure out how to deal with the issues of those who are far away from the center. Because even as we speak now, our outcomes from the center and the peri-urban areas is poor. So I would want to urge us that our low-hanging fruit for now is to focus on the urban areas and the peri-urban areas. When we are getting better outcomes from there, those people shift to the villages and all, then we'll be able to get to the village and get them to be better. That's the way, the strategy I would advise for now. That's what I would say.
Thank you so much, sir. Thank you so much, sir. Paulette, this question is for you. Are you here?
Yes, I am.
Okay, so this person is saying, for patients without any form of health insurance, are there arrangements to spread treatment for the full course of treatment, including diagnosis and investigations to monitor treatment progress over time in installments? I think what the person is trying to ask is, are there a plan in the cancer access program that gives installmental payments? That's the question. So the person is asking. Thank you.
Yeah. Thank you, Korede, for moderating so very nicely. And thank you for whoever asked that question. I mean, our role is to work with the Ministry of Health to support what the government is already doing to go for it. So the National Assembly, through the presidency, have approved what is known as the Cancer Health Fund, which was a major collaboration between private sector advocacy, cancer advocates and the government to just really get to that place where a portion of the money allocated for health in the budget goes primarily to cancer patients. So, for those patients that are then, and primarily for patients that are considered indigent, there's a criteria that's used. And so really, to answer that question, that's the first step. The second step is how do we grow that fund? How do we then get, maybe counterpart funding or counterpart support? But at the moment, the other good news is that CAP centers, so centers that are participating on the Cancer Access Partnership, have been selected to provide services to those patients receiving that Cancer Health Fund, so that the money that's allocated to them will go a long way. So for those patients, they will, their full treatment regimen will be covered. Unfortunately, that's only a subset of all we have, of all the cancer patients seen at our centers, but we anticipate that this will only grow and improve with time. But right now, there's no coverage there's no opportunity for instrumental payments or promise to cover for every patient except for those who are on the Cancer Health Fund. I hope that answers your question.
Okay, thank you so much. Thank you very much for that answers to the question. So this question, the next question, I'm going to be directing it to Mrs. Dorcas. Hello, ma'am. Okay.
Yes, I'm here.
Okay, thank you so much, ma'am. Okay, so there's a question that came up. Someone says, okay, what plan do we have to train nurses? To train nurses who are always with patients to develop high index of suspicion. So you're going to answer this question. I'm also going to give Dr. Joseph of the Dorcas Cancer Foundation to also give a give answer to this question. So I want to ask you, Ma, is there a plan? The person is trying to know, is there a plan for, with the ministry to develop nurses in pediatric oncology?
Thank you very much. The nurses are doing greatly in cancer care. If we go into records, currently the cervical cancer screening is on in Lagos, and it's also being carried out by CHI. But the aspect of training nurses in cancer care is the Nursing and Midwifery Council of Nigeria that has to organize that to bring it to bear. Are you getting me?
Yes, ma'am.
Because it is the regulatory body that makes training possible. But I am sure they are already developing a curriculum, but there is a process that it has to follow. We have oncology nurses, some of them that have traveled out, trained in oncology nursing, and they are back. We have one in Lagos that I know of. Okay, so we believe that Nursing Council can see the challenges at hand, and they are also trying to meet up with that to bridge the gap so that we can have more specialties in caring for our people. I hope that answers your question.
Okay, thank you so much, ma'am, for that question. Okay, I think there are answers also going to most of these questions in the chat and in the Q&A. So if you've got questions, you can see answers to some of your questions. I think I'm going to direct this question to Dr. Akinshetesa. Someone said, what is osteosarcoma? How could be treated because the issue of religion is affecting the management? I think the person says, okay, he's trying to talk about the issue of religion, and then wants to know what osteosarcoma is all about and how religion is affecting it. So I don't know if you can just give a brief on that, sir. Thank you.
Thank you. Basically, osteosarcoma is one of the cancers of the bone. And I would suggest that we don't see religion as against science. We should see them as our partners in the moving our outcome data up. Maybe we are all not at the same level scientifically now. That way, we will better get the buy-in of our religious healers so that they will understand that they should partner with us and they shouldn't antagonize the work we do. So osteosarcoma is a cancer of the bone. The modalities are, we give chemotherapy, there is room for surgery. And in some cases, if there is extensive disease, you may do radiotherapy. So those are just the basic things about about osteosarcoma. As I have said earlier, I don't think religion should antagonize us. They should actually partner with us to get our outcomes to be better. So I would advise practitioners to actually talk to those people who are trying to give alternative narratives as to what care the parents should give to the children. And maybe we'll be able to convince those people and get the children to get better care. But it's the three modalities: chemo, surgery, and in some cases of extensive disease, radiation. Thank you.
Okay. Thank you very much, sir, for that answer. I think most of these answers. Someone said, what is the role of pharmacists in closing the gap? What is the role of pharmacists in closing the gap? Mrs. Dorcas, would you like to just respond to that quickly, ma'am? Thank you, ma'am.
The role of pharmacists,
yes,
in closing the gap.
Yes.
Every profession in the health sector they are concerned to make sure we all close the gap to increase survival rate of the children. So in the capacity in which the pharmacist can close the gap is to make necessary drugs available, especially the chemo. Though very expensive, they also can be involved in advocacy for people that will be able to sponsor the provision of some of these drugs so that it can be made available to the people at subsidized rates. And the aspect of, anyway, we are not specific about any cancer now. The aspect of vaccine also, the pharmacists also, vaccination against cancer. The pharmacists also can also assist in bridging the gap in this aspect by making sure that those vaccines that are available to prevent cancer are overseen. Let's see how we can collaborate with developed countries, make it available for our people. As these children, they have, like one of the presenters said, they still have a long way to go and they are the future leaders of tomorrow. I think that's what I can say about the aspect of family closing the gap. Thank you.
All right. Thank you so much, ma'am, for that answer to the question. Thank you so much, everyone. Please check in the chat box, the post-event survey has been dropped. Kindly help us just quickly fill it. It takes less than 1 minute. You can check now. It's just dropped. Please check and let's quickly fill it. Thank you so much for your time. You can just, it's just been dropped now. It's going to be dropped again. So let's just try as much as possible to fill it now. We are coming to the end of this webinar, and so I will just allow our speakers to just give their last word as we wrap up. Let me start from Paulette. Just last word.
Sure. Thank you, Korede, for the excellent moderation. And I want to say thank you to the Dorcas Cancer Foundation, to all the other panelists here, to Her Excellency, Dr. Zainab Bagudu, who has consistently, blazed the trail around improving access to cancer care, to Dr. Uche and the National Cancer Control Program, who without, we wouldn't have the policy or the government will to continue to move these forward, to the entire team at the Dorcas Cancer Foundation, to the father who came and shared his his feedback, to Mrs. Dorcas, who is representing all the nurses, and just really to the Chai Nigeria team, the TDCF team, and but especially those who have joined as attendees and have stayed on until now. My last words are really that we cannot do this on our own. We cannot, as Dr. Shea rightly said, we can't continue to work in silos and expect to achieve a solution. We have to work together. And I think the theme for this year is act through our hands, right? Through our hands, we can all play our role, whether it's in raising the suspicion index, whether it's in raising funds, whether it's in negotiating with manufacturers to continue to drop prices, whether it's working with the FMOH around making sure that after those prices are dropped, they are available, whether it's working with the NHIS or with existing HMOs, as a question was asked, to just really find that solution, right? Because what we've learned is that the gap there is between the centers and the manufacturers and the distributors. The rate of reimbursement is not efficient, and so you have multiple months of owing millions of naira to the manufacturer, and they get fatigued to maintain supply. And what you have is the patient goes one day and fills their prescription, and they go another day and it's not available at the hospital pharmacy. So that's where right now the CAR program is a solution, and we will continue to work with every player to see how we can make it a lasting solution, such that even through the HMOs or for the HMOs or for NHIS, there's still a mechanism to pay immediately a patient receives care and reimburse folks. So again, I see chats going on about chemo safe, because again, even the healthcare workers are at some risk with dealing with these chemotherapeutic agents. But we will continue to work together to disabuse the idea that if an adult can't survive, then a child has no hope, when it's really the opposite, right? And so I just hope that we can get the word out there to the layman, to the professionals, to the experts, and together we'll all work together to just ensure that we see that graph that I presented, that we start to look very much like high-income countries, and that the two Marys that Dr. Shea presented have the same outcomes. Thank you.
So very much. Thank you, Paulette. So, Mrs. Dorcas, ma'am, maybe one or two final words as we wrap up now.
Thank you very much. I want to appreciate all the panelists, especially our Excellency that came on to address us. And I want to say that every one of us should try as much as possible to be an advocate for increase in survival rate of children with cancer. Thank you very much. And my take home is that my nurses need to be trained in oncology.
No problem, ma. Thank you very, very much. Dorcas Cancer Foundation will be willing to
Thank you, Dr.
Thank you.
Dr. Akinshete, for that. It's noted.
Thank you so much, ma. Okay, I would like to allow Dr. Akinshete to just give final word, and then we'll wrap up, sir. Sir, one or two words, sir.
Once again, I mean, my last. Thank you for I think all I would just ask is that as we all leave, we should write down 2 or 3 things today that we hope to achieve in the cohort of children we manage, and hope that in 1 year, 15th of February 2023, we will then review it and see how well we have performed with regards those particular outcomes. And I know that once we have the will, we will always create a way. Thank you.
Thank you very much, sir, for that powerful last word. Thank you. I don't, Dr. Uche, sir. I don't know if you're still here. Okay, I think Dr. Uche is somewhere. Excellency, ma. I think I don't know if Her Excellency is still on the call. Hello, ma. Okay. Maybe she's in another meeting already. But thank you so much, everyone. I'd like to pass over to my colleague, Dr. Azizat. Over to you.